Now we move on to Compressive Optic Neuropathy by Dr. Soumya Nambiar. She is a consultant in Pediatric Ophthalmology Department in Compressive Eye Hospital. Over to Dr. Soumya.
Thank you, madam, for the wonderful introduction. And good morning to everybody. So today morning we have been dealing with a lot of optic neuropathy cases. So when it comes straight on to you, you are basically confused. Oh man, what is this disc edema? What is it now? Is it an NAION or is it an optic neuritis? That is the first confusion that occurs when a patient comes to you. This topic, when you are talking, it is theoretically very okay. But when the patient comes to you and presents to you, it's totally a different scenario. So today I'm going to talk about compressive optic neuropathy. So what do you mean by compressive optic neuropathy? It is a damage to the optic nerve by pressure within the optic nerve or from nearby structures. So it could be a compression, as I said, because of an intrinsic cause, or it could be due to an extrinsic cause. Okay. So how does the damage occur? It could be because of the direct pressure because of the mass. It could be because of the vascular compromise because it's compressing on some vessels, or because of axonal damage. So before knowing where, you know that this compression can occur in different parts of the optic nerve. It could be the intraocular, intraorbital, intracanalicular, or intracranial. Intraocular or something very near to the eye, definitely you may not miss it because it will present with a disc edema, but something behind, that is when you have to be very cautious, right? So to just give you a picture of this is a cadaveric dissection. You can just see how the optic nerve is. That's the eyeball, which you can see. I don't know if you can see my pointer. Okay, so you can see the optic nerve and just see the vessels that is around. You can see the cranial nerve 3, the 6, and the muscles. Any infection, any mass in these areas can lead to compression. Okay, and this is a dissection in the intracanalicular part. So you can see this optic nerve which has been dissected here onto your right side, and you can see the ophthalmic artery just beneath and an internal carotid artery. So this bony, it's a just small canal, the intracanalicular part, and radiologically, every chance of missing this lesion, even radiologically. Okay. This is to emphasize how the optic nerve is joining the optic chiasma. You can see the pituitary gland just beneath, and any tumor there can cause compression on the optic nerve or the optic chiasma. And this is the coronal view of a dissection that is done. When you have a coronal view in a radiologically, you can see this picture. You can see the optic nerves beneath. There's a internal carotid artery and a pituitary gland. So any infection, any inflammation, any vascular cause, any trauma, any neoplasm, any bone tumor, all these can cause compression. So let's see each of these one by one. An intracranial segment, this is what I'm showing you initially. So you can see that there is an optic chiasma right above, there is a pituitary stalk connecting, and the pituitary gland. Beside that, you can see the internal carotid artery that is coming, right? And therefore, for an optic chiasma directly to be involved, a glioma or a demyelination can cause, or a aneurysm of the internal carotid artery can cause a problem. A sphenoidal sinus issues like a squamous cell carcinoma can cause. Something coming from above, that is hypothalamus, causing a compression on the optic chiasma can cause damage. The cavernous sinus lesions, schwannoma, or a keratoconus fistula can cause a damage, or any problem with meninges, that is meningioma and inflammation can cause. So let's see each one case by case. So I had a case of a 67-year-old female. She came with a history of diminution of vision of both eyes since many months. Initially, she presented to the general ophthalm OPD. There was no history of trauma and history of difficulty in walking since 1 year. And there was a past history of some nasal surgery during childhood. Now, she was first initially referred from the general ophthalm to the glaucoma department because of the large size cup that the doctor observed. And in the glaucoma department, a gonioscopy was done, AC was found to be shallow, but IOP was on the normal side. But because there was a squint, she was referred to the squint clinic. So in the squint clinic, again, I take up all the full history of difficulty in walking is there still, and there's a past history of some nasal surgery done, but history of squint was not present in childhood. She gave me the history. It's present only since 1 year. So this is a picture. You can see there's large angle of left exotropia that is there. You can see on general physical examination, because of the nasal surgery, there's a saddle nose there, okay? So extraocular movements, you can see on the right side and left side, there is an adduction limitation in both eyes. And pupil, this is very important, pupil was round, regular reacting, but sluggish in reaction. So that is when something has to click to you, there is some problem. Cataract, there is a NS1 to 2 cataract. Fundus, you see, mild dyspallor, very difficult to detect, okay? And as we told, cupping was there around 0.6. Color vision was tested, it was normal. I got a fields done. You see a bitemporal hemianopia. You cannot miss that out, right? And an RNFL also showing that there is a thinning there. And an MRI shows a big figure of 8 cellular mass there, sitting right over there, okay? So this is something which cannot be missed, okay? So this was a case of what we call as a pituitary macroadenoma, okay? So the red flags here was a recent onset squint. There was a gait abnormality if you have taken a history properly. A pupil examination showed bilateral sluggish pupil, and fundus showed a temporal pallor in spite of having the cupping. Look at that carefully, okay? This is a case 2 of a 10-year-old child with a history of squinting present since 6 years of age and gradually progressing. The parents gave a history of hypoglycemia and bradycardia in the childhood, and she was seen elsewhere before 2 years back. Vision recorded at that time in the right eye was 636, in the left eye it was 612. Mild dysphalia was recorded in the previous report. A neuro opinion was advised. They didn't go. For 2 years, they have not gone anywhere. They sat right at home. And then they come here with a right exotropia to me. And there's a large left face turned to the child. And on recording the vision, now the vision is 660 in the right eye. Left eye it is 624. Pupil, again, you can see sluggish reaction OU. Color vision is normal, right eye. Left eye it is normal, right eye it is abnormal. And fundus shows a primary optic atrophy feature. And this is her HFA field. So you can see right eye there is an advanced field loss, and left eye there is a temporal hemianopia. So this is her RNFL and GCC. It's completely thinned out. Okay, and an MRI done shows that there is an adamantogenous type of craniopharyngioma. Okay, and that shouldn't have been missed out. She's been sitting here there since 3 to 4 years with that mass there. Now, this is a case 3 of a 20-year-old male. So this guy, he comes to the general ophthalmology OPD, and he's a differently abled child with a low IQ. You cannot rely upon his history completely. But he did give a history of sudden reduced vision in the right eye. No history of trauma or pain or anything of that sort. And vision recorded in the right eye in the general ophthalmology was hand movements, and left eye it is 6/9. Okay, they refer probably because he was not very cooperative. So whether it's reliable, the vision, we do not know. Okay, so pupil recorded in the OPD was like it was sluggish and fundus was normal. They suspected a malingering. Okay, and when they came to a squint clinic, I took the history again. History of hypoxia, hypoglycemia is present at birth. There is a speech therapy issue. There is a delayed development. So my mind, I was thinking about CVI features and all that. Okay, vision, but why vision sudden loss? If you rely on the history, hand movements, still hand movements, left 6/9. So pupil, there was a grade 1 RAPD, not very much, and extraocular movements full. And color vision, I tried with the tracing method because you cannot rely on his history, a tracing method for the Ishihara chart. And it was supposedly normal in the left eye, right eye because of hand movements, I couldn't check. Fundus was normal, literally normal, except for slight amount of pigmentation on the right disc. And confrontation was not cooperative, so I did a field test with the Berams. This is the old one. Okay, field, I do not know whether he will be cooperative. So you can see that in the right side field, there is some field loss that is there. Somehow he cooperated for that. And I did an MRI after that. It was a exophytic atypical pituitary adenoma, and it came out to be a pituitary, an apoplexy in the pituitary macroadenoma, and his hormone levels also were very high. So the points that I learned was that a large cup may not always be glaucoma. A gradual loss of vision indicates that it is a slow growing tumor. Vision 6/6 may not always be normal. You have to be careful. Squint evaluation has to be done very carefully. HFA is mandatory for the normal eye as well. And pupil, you may not have RAPD if both eyes are affected symmetrically. And OCT RNFL can help as a prognostic factor. Okay, and this is just to go through it. This is a case of leash nodules with neurofibromatosis. And you have to remember optic nerve glioma that is common in neurofibromatosis. So how do you differentiate a meningioma and glioma? You can see that in glioma there will be a kinking of the optic nerve. Okay. A meningioma, what you can see is you can see sheathing along the optic nerve. So pearls here is, if the lesion is more anterior, as I told, there will be a true disc edema. Posterior only is the problem. And posteriorly, you can detect if there is an RAPD, but there may not be proptosis, and look for the disc carefully. And visual field is diagnostic. Okay, intracanalicular part I've already told, difficult to detect, and not the most common thyroid eye disease that cannot be missed because of this amount of proptosis if it presents like this. Okay, thank you one and all.
Thank you, Dr. Soumya, for that wonderful illustrative presentations of the cases as well as the anatomy. Wonderful illustrations.